Hello, everyone. I'm Muriel Finkel, and on behalf of the ASG, we welcome you to our ATTR amyloidosis webinar. We've actually Zoomed some face-to-face local meetings, and we hope to open up meetings in even more cities as the hospitals open up their venues to us. We had a meeting in Phoenix in November. We've got a meeting coming up in LA in February. We've got a Salt Lake City meeting scheduled in May. They have something going on at Houston Methodist in March. So we're working on Boston and New York. So one by one, slowly, we're dipping our fingers in the pie, and we'll be getting in more. And we do announce all of these meetings in our Facebook group. We send out emails. They're on our website. So, but if you have any questions, you can always email Muriel at amyloidosissupport.org. Now, this webinar is being recorded and will be up on our website and YouTube channel in a couple of weeks. Okay. For today's webinar, you will not be able to post comments in the chat. Paula will be posting links and other valuable information in the chat section. And speaking of Paula, in the control room today, we have ASG's Executive Director, Paula Schmitt.
Hi, everybody. Glad you could make it today.
And our Special Projects Director, Bob Gibson.
Hello, everybody.
Okay, I'm cute today. Good. We appreciate you emailing in your questions. There's a lot of them. We did set aside some extra time today so that we could get to them. So we hope to get to all of them, because I know that's a big issue with a lot of you. So if we don't get to them in the middle of the program, we'll get to them at the end, but we're going to try and get them all in today. Our presenters today are cardiologist, Dr. Matt Maurer. Oh, there he is. Okay. From Columbia University. And neurologist, Dr. Chafic Karam from the University of Pennsylvania. By the way, we do want to send out well wishes to Dr. Jignesh Patel of Cedars-Sinai. He joined us at our last webinar, and unfortunately, he's ill right now. We'll also hear from our pharma liaisons, Alnylam Steve Roblin, BridgeBio's Jocelyn Ashford, Intellia's Joy Olbertz, Ionis's Gustavo Buchele, Novo Nordisk and Ersbøll, and Pfizer's Craig Spolsky. There'll be a quick survey when the meeting's over, and we do ask that you take the time to fill it out. It's really important for us, and it helps us in developing future webinars. That's how we know you want more time for Q&A today and why we've set it aside. We're going to be referencing treatments today that can be seen on our treatment chart. Bob will be putting it up there so you can see it. There we go. Okay, great. Thank you, Bob. You can take a picture of it or print your screen, or you can feel free to email me for a copy, so you don't have to wonder how to spell any of the treatments that we talk about today. Okay. Now, joining us today, we will, and oh, I'm sorry, we already went through this, but let's open up and let's hear from our first presenter from Columbia University, Dr. Matt Maurer. Dr. Maurer.
Thanks so much for having me. Hope everyone can hear and see my slides. Is that, are you able to see them?
Yep.
Great. So these are my disclosures. I always mention the cost of drugs because, as we all know, if they're too high and patients can't afford them, they don't take them. And if you don't take them, then they don't work. So that's something I think we do need to work upon. I did want to mention a huge loss to the amyloid community. My colleague, Claudio Rapezzi, unfortunately passed away recently. For those of you who don't know, Claudio was the co-chair of the what's called ATTR ACT trial that led to the approval of tafamidis. I had the pleasure of working with him, and he was a lovely man, very curious, really a master of medicine, and always able to kind of make these what I call Rapezziisms, these associations that were supernatural. And for those of you who are diagnosed by what we call scintigraphy, PYP or DBD, Claudio brought that technique first in humans and was credited with helping us all to facilitate a non-biopsy diagnosis. So a great loss for the amyloidosis community. So to remind everyone, systemic amyloid, which is what we're talking about today, is a group of disorders that's caused by deposits of proteins that form fibrils. And these deposits can get stuck in any organ. In this case, today, we're talking about the heart. And there are dozens of proteins in the body that can form amyloid fibrils in various organs. But as I think appropriately, but jokingly like to say, us cardiologists aren't that bright. So we focus obviously on two main types of amyloid, that is light chain amyloid. And today we're going to focus on transthyretin, and particularly the wild type form, not the variant form. A variant due to a genetic mutation, wild type, in which the sequence of the TTR gene is normal without any variants. There's no real risk to family members being affected. Just for nomenclature, it gets confusing, but amyloid's the term that refers to the protein deposits. They form a structure that appears very starch-like, hence the name amyloid. Amyloid fibrils are the aggregates of proteins that fold into a particular shape, allows many copies of that protein, as I'll show you in a video, to form these fibrils. And amyloidosis is different from amyloid. That is the disease that results from the deposits of the amyloid fibril. So slight differences in names in case you get confused. So just to remind you, this is a quick video that shows the synthesis of proteins. Some of these may have some sound, and I'll try to speak over the sound. But you can see here is a nucleus of the cell in which the DNA is opening up. And we have two copies of our DNA. And what we do is we transcribe a messenger or mRNA from the DNA by linking pieces of DNA and RNA. The RNA then leaves the cell, and while it is leaving the cell, it then gets transcribed. And you can see every 3 codons here leads to essentially the production of various amino acids that are shown in these small little circles down here. You may recall that every protein is constructed or made up of 20 different amino acids. And as time passes, a protein is made. This makes it seem like it's a very slow and inefficient process, but in the last minute or so, we've all manufactured probably a million different types of proteins in our body. So proteins are actually the most abundant thing around in the universe as molecules other than water. And a single protein needs to be folded in a tightly complex shape and structure in order to function appropriately. And if you actually think about it, one single protein has about 10 to the 16th, so billions of different ways to figure out its conformation. And so the fact that proteins actually fold in a normal manner is kind of a testament to a human biology. And here is an example of proteins. And so you can see these are the amino acids forming a single protein. And this is called the primary structure of the protein, in which it's formulated by each of the amino acids. And you can see here the protein is folding upon itself, where here there's a helix, a circle, and here is the classic beta-pleated sheet. So the hydrogen links these together. Then the protein subsequently folds further, as you can see here. So some proteins can form, as we said, this quaternary structure, and TTR is one of those proteins. So here is the structure, by the way, of transthyretin. It's a molecule made up of 4, if you will, separate monomers of the TTR protein. You can see each has that corkscrew to it, the so-called alpha helix, and then each has a very heavy beta-pleated sheet structure, these ribbons running back and forth. And that's what makes transthyretin very amyloidogenic, because it has a lot of beta-pleated sheets with this tetrameric structure. Variants in the protein that patients with wild type don't have contribute to this protein falling apart into pieces. And to be honest, the pathogenesis of what causes wild type disease is thought to be analogous to variant disease. as I'll show you in a minute, but is less well understood. So this is the presumed biology of the disease. Here's transthyretin and its 4-leaf clover. It can fall apart into pieces or monomers, and these monomers can form fibrils that can deposit either in the heart or the nerves, causing what patients experience clinically. And so here is just an example of a cartoon of a protein trying to find its normal right shape. And you can see, you can imagine every protein is folding based on its amino acid structure and trying to formulate its right shape. Here, this particular protein is getting a lot of beta-pleated sheets that are aligning up in a certain way. And that beta-pleated sheet structure can then allow additional proteins to line up alongside one single protein's beta-pleated sheet and form these fibrils that can aggregate pretty quickly. And so you can see how these can formulate an amyloid fibril. So the two main forms of amyloid that we think about in the heart are quite different. AL and TTR, they differ in their precursor protein and biology, their natural history and prognosis. I mentioned the genetics that is present in some patients with TTR, but not wild type patients. And obviously the treatment is different. And so the most important first step is to make sure you know what type of amyloid you have, and then it's been verified by someone who has significant expertise in distinguishing the different forms of amyloid. Once you understand the biology of the condition, that there's a liver making a protein that looks like a 4-leaf clover and dissociates into monomers that form the fibrils, you can then begin to understand the emerging strategies to treat this problem. So one is an ability to, if you will, knock down or silence the TTR protein, shut off its production at the liver cells. And that's done by either antisense, ASOs, small interfering RNA, or potentially in the future, even CRISPR-based therapy. A second approach is to stabilize the protein, not allow it to fall apart, and that's done with drugs like tafamidis, diflunisal, off-label, or maybe even acoramidis, which is in clinical trials, or AG10. And then the final strategy, at least for TTR, I've shown some therapies that are potential here. PRX, which is now owned by Novo Nordisk, but was the Prothena compound, which these are antifibrillar therapies. They work at pre-existing amyloid and trying to activate macrophages and lead to the degradation of amyloid that already exists in amyloid fibrils. So I always want to spend a little bit of time talking about how clinicians assess heart function and why the commonly used measure, the EF or ejection fraction, is not a good measure in patients with amyloidosis. Ejection fraction is the amount of blood that the heart pumps in the numerator divided by the amount of blood that the heart holds. So in these examples, here's a normal heart with a normal thickness. The blue shows the heart muscle, and the heart contracts and thickens up to expel the blood. And you can see inside the heart in a normal patient, it might hold 100 milliliters of blood. And when it's done contracting, it holds 30 milliliters. So the difference between 100 and 30 is 70. And so this heart would pump 70 milliliters and it held 100. So the ejection fraction is 70%. Here is a heart in someone with amyloid. And I think you can see in blue, the heart wall is much thicker and the chamber is much smaller. The heart's still pretty good at contracting, and it thickens even more and it gets smaller. And in this example, this heart can only hold 50 milliliters of blood because the walls are thicker and it's leatherier and it's stiffer. The heart may contract down to 15 milliliters. So the difference between these is 35 mLs. But if you divide 35 by the 50 that it holds, you get the same percentage. That is, the ejection fraction is identical. And clearly these two hearts are functioning very differently. So an alternative way I like to educate my patients about and thinking about the heart is the cardiac output. That is how much blood the heart pumps. And the cardiac output is equal to the heart rate times the stroke volume. The stroke volume is the amount of blood the heart is pumping. And so if your heart rate is 70 milliliters, 70 beats per minute, and your stroke volume is 70 milliliters, like I showed before in a normal patient, this becomes 4,900 milliliters a minute, or about 5 liters of blood being pumped around every minute. In a patient with amyloid, the cardiac output would only be 100, because the heart usually goes faster, in part because the stroke volume, as I showed you before, was 35 mLs. The heart had trouble filling, and therefore the stroke volume was limited. In this particular circumstance, the heart would only deliver 3,500 milliliters of blood every minute, or 3.5. So again, same ejection fraction, 70%, but markedly different outputs of the heart. And so therefore, ejection fraction is really not a good surrogate for what's going on. Here's a picture of someone with, unfortunately, pretty advanced cardiac amyloid. You can see here's the main pumping chamber of the heart, which is the left ventricle, and you can see the walls are very thick. The chamber here is very small. These are the atrium, in which they're even bigger, if you will, than the capacity of the ventricle, which is not normal. And what this happens to patients is that the heart gets smaller and smaller and smaller, as indicated by these curves that are upward shifting as more amyloid deposits. And as I explained, the cardiac output tends to decline in patients. And the decline in the cardiac output, you can see here, leads to a decline in your blood pressure. So this is the systolic or top number of your blood pressure. This is the bottom number in red, and you can see the blood pressure declines and the difference goes down. So this physiology results in declines in output of the heart, stroke volume, and blood pressure, and patients often feel more fatigued, more tired. And if they were on standard medicines to treat high blood pressure or heart failure, they usually do not like them and they're intolerant of such therapies. We've shown that standard medical therapy that's used in regular heart failure, including beta blockers or what we call ACE inhibitors or angiotensin receptor blockers, are not associated with any significant improvement in survival. These are what are called survival curves, and they overlap such that getting these medicines when you're in blue versus those who didn't is not associated with any clinical improvement in outcomes. Interestingly, what we did find was that in patients who are on a beta blocker at baseline, all of these patients were, when we stopped the beta blocker, removed it from their medical therapy versus in those who was continued, survival, this is outcomes of living longer, was markedly improved in patients who we stopped the beta blocker. And so certainly beta blockers should be used cautiously, I think, in patients with amyloid. They're medicines that slow down the heart rate. If you're requiring a faster heart rate to maintain your cardiac output, you can imagine slowing down the heart rate may be contrary to what the heart really wants you to be doing. We've also shown in studies that we've conducted that the higher dose of the diuretics that you're taking, not because diuretics themselves are bad, but they're a marker of worsening disease, are associated with worse outcomes. These are also survival curves, showing that if you take no diuretics, you do much better than patients who take a large amount of diuretics per day. And one thing that's emerging in the world of cardiology that I think is going to be quite helpful for patients with amyloidosis is the fact that as the disease progresses and the cardiac output goes down, patients often develop rises in their kidney function, what we call a cardiorenal syndrome. And there are drugs that have been invented that were originally designed to treat diabetes. They're called sodium glucose cotransporter inhibitors. One of them is Jardiance, the other is Farxiga, and these are drugs that have been shown to be useful in patients with heart failure and chronic kidney disease, and we've been using them in patients with amyloidosis to ameliorate some of the clinical symptoms and avoid the use of high-dose diuretics. That's something I think that should be considered and we can talk about. This is an example of a study patient that we're actually conducting with these agents, the sodium glucose cotransporter inhibitors. We invited 15 patients with amyloidosis to get one of these agents for free for 12 weeks, and we've been studying various physiological parameters. But here's a patient who's 90 years of age. She started with an NT-proBNP of almost 10,000. You can see over time her NT-proBNP on one of these medicines came down. This is what would happen if her renal function got much worse. We would have stopped the study, which it didn't happen in her, just shown in red. Her renal function actually stayed stable by her creatinine. In fact, her estimated GFR was slightly improved, and the dose of diuretics that she needed during the study of the 12 weeks was reduced. So we think that these agents might have a lot of clinical utility. To remind you again in my cartoon, this is transthyretin, a four-leaf-like clover protein that, as I mentioned, dissociates into pieces and forms the amyloid fibrils. And this is what tafamidis as a TTR stabilizer does. And this is a similar diagram to what Muriel was showing. These are patients, these are data from the European guidelines to treat amyloid, in which you can see across the spectrum of disease, whether you have wild type or variant disease. Currently, tafamidis is approved in many countries. And for patients with wild-type disease, currently tafamidis is really the sole therapy that we have that's got FDA approval. Tafamidis, like a drug called diflunisal, both discovered by a famous scientist named Jeff Kelly, binds here in the dimer-dimer interface of TTR, and basically, as I showed you, prevents the protein. These are each of the monomers from falling apart into pieces. And so, again, this cartoon shows where tafamidis or Vyndamax, Vyndaqel lies, and in the ATTR ACT trial that I mentioned, I had the privilege of leading with Claudio. There were significant reductions in mortality and significant reductions in the risk of being hospitalized compared to patients who didn't receive tafamidis, which led to its approval. Tafamidis is a very well-tolerated medicine and quite excellent, but unfortunately is associated with not improvements in functional capacity, but a slowing of the decline on aggregate in patients who received it compared to placebo. And the same for the quality of life measured by this scale. Certainly patients on placebo fared worse than those on tafamidis, but everyone was still, unfortunately, on average, declining. And so the success of tafamidis for this disease has led to a plethora of additional studies that you'll hear about later today, which we're all very excited about in the amyloid world as clinicians. Obviously, our goal is to bring new therapies to patients, and we're quite hopeful for many of these. So just quickly, there's a drug called acoramidis, super tafamidis, which is being studied in the ATTRibute-CM trial, and we're waiting for the results of what's called Part B, which is the hard endpoint similar to the tafamidis trial, looking at mortality and hospitalizations. There's patisiran, and I'll quickly show the Apollo B data. This is a silencer given IV every 3 weeks that met its primary endpoint. And then there are two, you'll hear more, subcutaneous silencers that are administered without pre-medication, one delivered every 3 months, once every month. And there are ongoing clinical trials that we have high hopes for. One that's enrolled 655 patients, and one has a very large number of 1,400 participants. And this latter trial is still recruiting throughout the world. Just to give you a picture of how TTR silencers or gene silencing works, here's the, if you will, antisense or small interfering RNA or CRISPR-based therapy. It goes into the nucleus in the hepatocytes, and it finds the spot where TTR is made, and it basically silences the production of protein. And this can be done for any genes in the genome, assuming you can deliver the therapy to the organ where it's being made. So the hypothesis here is that you're making a wild-type protein that becomes unstable. It deposits in your organ and causes the cardiomyopathy or the neuropathy. And by blocking the protein, we can reduce the unstable pieces, we can prevent the deposition in the organ, and we can stabilize the problem, or we hope potentially begin to see reversal. These are the data I mentioned from the Apollo B trial that was successful. This is the placebo group, and you can see at 6 months, 12 months, 9 months, and 12 months, they had progressive declines in their 6-minute hall walk. And the patients who received patisiran were significantly different and stable, with an average difference in the hall walk of nearly 15 meters at 12 months. And this is the quality of life measures that were stable in the patisiran group and declined in those patients who were not receiving patisiran. These are the echocardiographic data, and I'll just note a measure called strain, which measures systolic shortening, and the ability of the heart muscle to contract was improved. Heart mass, presumably related to amyloid deposits, was also better. And the chamber size was improved in patients. And most notably, these are data looking at what's called the stroke volume. That's the amount of blood the heart's able to pump every beat. And you can see it increased a little bit in patients on patisiran, staying stable, and declined, unfortunately, in patients on placebo. Finally, many of you are very excited, as are we, about the CRISPR technology. This is gene editing in which you permanently silence TTR. This is grown out of Nobel laureate work discovering this system called CRISPR-Cas9. This is like a scissor that can cut your genome and eliminate a particular gene. And with a guide that brings the scissor, if you will, to the right spot in the genome, because you don't want to cut somewhere off label, and a single intravenous infusion, you can get delivery of this to liver cells where it permanently shuts off the production of TTR. And Julian Gilmore and colleagues presented data from cardiac patients, including patients with wild type disease who had either class 1 or 2 disease or even class 3, and showed that the knockdown or reduction in the transthyretin was very impressive with this particular single infusion-based therapy. Finally, there are the anti-amyloid therapies that I mentioned. There's the Novo Nordisk compound, which used to be the Perfina compound, that's in phase 2, recruiting patients. There's NEOD01 and the Karam, which are for AL, and there are Neurimmune and Astralis have anti-amyloid therapies that are either in phase 1 or preclinical and are expected to hit the clinic soon. How do these therapies work? Well, shown here, they target a particular spot on the misfolded TTR, and they basically use a monoclonal antibody that's humanized, and by binding there, they activate what we call macrophages. These are cells like Pac-Man that can then begin to chew up the preformed amyloid fibrils. So I'll just conclude by noting this chart in which you can see here we are back in 2011 when tafamidis was approved for patients with TTR polyneuropathy. We had the results, beginning enrollment, I should say, of the ATTR ACT trial and the final results. We've created non-biopsy approaches to making a diagnosis. National organizations have published guidelines on how to manage patients, and we're very excited about the plethora of potential therapies that will, we hope, soon emerge positively, and some of which have emerged, that can dramatically improve the quality of life, functional capacity, and outcomes for our really, really, really lovely patients. So thanks again for your time and attention.
Thank you so much, Dr. Maurer. And a reminder that Dr. Maurer will be back in a few minutes after Dr. Karam's presentation to answer questions along with Dr. Karam. And also, we will have these presentations up on our website and on our YouTube channel within a couple of weeks. Okay, so thanks again. And now we will hear from Dr. Karam about everything you wanted to know about neuropathy, right, Dr. Karam?
Correct. Thank you again for having me. So we will switch to the neurological complication of amyloidosis. This is the outline of this talk. We'll just start with an introduction for people who are not very familiar with the brain and spine and nerve, and then we'll talk a little bit about how amyloid damages the nerve, what are the signs of neuropathy and nerve and central nervous system involvement in amyloidosis. How do we typically detect amyloidosis, the challenges that we face, and then talk a little bit about the treatment strategies. Dr. Maurer did summarize very nicely already, but I think sometimes repetition is useful. So let's start with an overview of the neurological system. It consists of 2 parts, and neurologists like to make this separation. You have the CNS, or the central nervous system, which consists of the brain and the spinal cord. And then you have the peripheral nervous system, which are these cables that kind of transmits the sensation from part of the body back to the spine and eventually to the brain. And they also send a signal from the brain down to the spine and then eventually to the nerve endings. And this is important because a lot of the time that we spend as neurologists is try to localize where the problem is coming from, because the symptoms can be very similar at any interruption of the signal. I tell my patients, think about the brain as an electrical power house, and then you have the electrical cable that go down the spine and the body. And if you have a power failure, it could be really anywhere. It could be from the electrical cables, meaning from the nerves, or it could be in the spine, or it can be from the brain itself. Another interesting part of the nervous system is the autonomic nervous system. And the reason why it's called autonomic is because it's autonomous, meaning that we don't think about it. It just controls our organ without us having to consciously think about it. So for example, you don't think about regulating your heart rate or asking your bowels to move. or bladder to empty, this is kind of a reflex that tells you, oh, the bladder is full, I need to empty it. And then when you want to empty it, it empties on its own. You have a reflex where it tells you, oh, the blood pressure is low, we need to raise it, let's increase our cardiac output, let's contract the blood vessels. And all of this is controlled by the autonomic nervous system. And if there's a failure, you're going to have symptoms depending on where the failure is happening. Another important concept to understand in the world of neurology and neuropathy is that we have two types of axonal damage. We have demyelination, where the myelin sheath, which is, if you go back to the electrical cable analogy, you have the copper inside or the metal part inside, and then you have the insulation outside. The insulation are the Schwann cell and the myelin, and if these get damaged, a lot of time you can recover if you remove the cause of the damage. For example, early carpal tunnel syndrome, it starts with demyelination, and if you treat it early, then you may recover nicely, but if you don't, it will eventually lead to axonal loss, which will cause irreversible nerve damage. The peripheral neuropathy itself in amyloidosis is unfortunately of the axonal type and not of the demyelinating type. But when you have compression of the nerve, usually the myelin is what is lost first, so there's a chance of recovery. Axonal damage does recover, but a lot of time it's not a perfect recovery, and it depends on how much axonal damage you've already had. And sometimes you have partial recovery, sometimes you have complete recovery, sometimes, unfortunately, you don't recover much, and all we hope is to stop the progression of the disease. So Dr. Maurer told you a little bit about where this transthyretin, or we call it TTR, is produced. It's mainly produced by the liver, but other organs produces it as well. And this is very important to understand because it has implication on the treatment. So the liver is what the silencer, such as patisiran or onpattro and inotersen and Tegsedi, targets the liver. But you also have local production in the brain and the eye. And unfortunately, currently, we don't have treatments that are approved that are able to target these organs. So if you have amyloid deposition in the brain or the eye, the treatment is kind of challenging. You also do have local production in other organs. So the Schwann cell, the nerve can make a little bit, the pancreas can make a little bit. So a lot of the organs can make that protein, but the majority in the bloodstream that you see is coming from the liver. So that's why targeting the liver is a very effective way to treating patients. You already saw this picture here. It tells you how the protein is produced, the transthyretin, which has an important role. So it is a protein that is useful in humans. It transports thyretin and retinol, which is vitamin A, and hence its name, transthyretin, because it transports these two things. I get a lot of questions about if you suppress the production, will it affect the thyroid hormone? And the answer is no, because most of the thyroid hormone is transported by another protein called albumin. The vitamin A level, if you take a silencer, will drop down dramatically and it will remain low. And the recommendation is to take the daily supplements of vitamin A. Now, when this protein kind of destabilizes, dissociate from its normal tetrameric, it has tendency to misfold and cause amyloidosis, which sticks to the organ, to the liver, to the heart, to the kidney, to the nerves, etc., and causes toxicity and damage to these organs. This is just a picture of a nerve biopsy showing you where the amyloid is depositing, occupying. You see this kind of pinkish material occupying the nerve. For some reason, my mouse is not working, but anyway. Sometimes the amyloid can involve the blood vessel, and as you can see here, you have to be very careful. It could be missed if you're looking on the nerve quickly and not paying attention. You're not being very careful. And then you have to put a specific polarizer lens to kind of demonstrate the apple green birefringence, which is shared by all amyloid proteins. So it's not specific for TTR, it could be anything. And that's why it's important to investigate this protein with mass spec or other ways to determine what type of amyloidosis you're dealing with, because the treatment is very different. Obviously, people with AL, they're going to get chemotherapy. People with transthyretin are going to get gene therapy or stabilizers. So the ATTR comes in two flavors. There's the heritage ATTR, and now we call it TTRV for variant. This is a variant or a mutation in the genetic composition. We do a genetic testing. We usually get the results within a few weeks. And it's important to do this test because the implication on the family members. This is an autosomal dominant condition. So unfortunately, each child will have a 50% chance of inheriting the disease. And, you know, brothers, sisters, etc., cousins can also be affected. So we always try to convince people to get genetic testing to see if they carry the condition or not. The other flavor is the wild type ATTR, and that is where you do the genetic testing and people do not carry the mutation. So there's no chance that you're gonna pass this to your children, but the treatment is kind of converging to be very similar these days. So what are the neurological signs of amyloidosis? In neuropathy, the most common presentation is what we call a length-dependent neuropathy, meaning the most distal aspect of your limbs get affected first, and as the disease progresses, it starts kind of progressing and climbing up. So usually people start having numbness, tingling, burning sensation, or weakness in the toes and feet, and as the disease progresses, it start involving the ankle, the mid-shin, the knee, and at that point, usually the hands get affected. Now, one of the characteristics of amyloidosis is a condition called carpal tunnel syndrome. So a lot of time the hands can be affected more, but that's not the definition of neuropathy or polyneuropathy that neurologists use. This is more of a focal mononeuropathy caused by compression, and I'll show you pictures of that. So the symptoms, numbness, burning, prickling sensation, cramping, pain to light touch, which we call allodynia, and that's when you're laying down and the sheet are just barely touching your feet and you get kind of uncomfortable and pain. Your balance can be affected because the signal is not going to your brain and you don't know where your feet are in space. The motor aspect of the nerve, where you start having weakness, dexterity issue, tripping on your toes or feet, and difficulty standing on your tiptoes, difficulty opening a jar, holding a pen, etc. And of course, the dysautonomia or the autonomic failure, which we'll talk in more details in a little bit. So how do we diagnose neuropathy? Usually you want the patient comes to you with symptoms, but a lot of time they don't know that they have neuropathy because they're concerned about their heart failure. They have a lot of heart issue, and the neuropathy may be subclinical, meaning that when the neurologist examine you and do the nerve conduction study, etc., they detect that you do actually don't feel very well in your feet and you have neuropathy. And that's important right now for treatment as well, because as you know, and as Dr. Maurer showed you, the treatment that are approved by the FDA are different for neuropathy and cardiomyopathy at this time. I think things will change in the future. So autonomic dysfunction, obviously very annoying. It's really affect the quality of life dramatically of people when it's affected, because it causes a lot of very bothersome symptoms. In men, very frequently, they start to have erectile dysfunction, ejaculation problems. People get constipation, diarrhea, sometimes both, sometimes soiling. I have a lot of patients who cannot travel because they need to constantly be close to a bathroom, incontinence, early satiety because your stomach doesn't contract and empty very well, which will cause weight loss, nausea, regurgitation of indigested food. OH, which is orthostatic hypotension, and I'll talk in the next slide a little bit more in details about that. Heat intolerance, your body is not producing sweat very well anymore, and when it's hot outside, your body temperature rises and it causes a significant problem. You feel very sick and you can pass out. So orthostatic hypotension, a very challenging problem for people who have it. They get lightheaded when they stand up. They may even faint if the orthostatic hypotension is severe. They get dimming of the vision. Sometimes they get a little bit confusion. They get short of breath. They get kind of a hangover, coat hanger, we say headache, where the neck and shoulders feel like a lot of pressure. They sometimes get chest pain and fatigue on exertion. Climbing stairs, they may pass out. If they're on the bathroom and they are constipated and pushing, they may also pass out. So a lot of time you're laying down at bed at night, you want to get up to go to the bathroom, and then you feel lightheaded and you may pass out and injure yourself badly. This is down on the right lower corner, a picture of a tilt table test where we measure the blood pressure and the heart rate when people are tilted up. But you don't necessarily need to do that. You can do it anywhere. You can do it at home or in the clinic. If you have a blood pressure cuff, you have the person sit down for a few minutes and then sit up, and then you take the blood pressure at 1, 3, and 5 minutes and see if it's dropping. If it drops more than 20 points on the systolic, that's by definition orthostatic hypotension. And if people are on blood pressure medication, that can make the symptoms worse. One of the challenges with this condition is that they can also have a supine hypertension, meaning that blood pressure can be very high when they're sitting, and that's just a way for the body to kind of compensate for the drop in blood pressure. And that can be also difficult to treat, or it can drive the clinician to give a lot of blood pressure medication, which will make things even worse. Carpal tunnel syndrome, a very common problem in people with amyloidosis, and it's different from what we, as I mentioned before, neurologists consider as polyneuropathy. This is more of a compression problem. So you have the amyloid that deposit in the transverse carpal ligament and can cause pressure on the nerve and cause symptoms with numbness, tingling, burning, weakness in the first 3 digits of the hand. A lot of time these symptoms can wake up patients from sleep, and they have to shake their hands. It's a very common symptoms that people present with. They shake their hand at night to kind of bring it back to life if you want. It's a treatable condition. You can treat it with injection, and you can treat it also with surgery, and usually the outcome is pretty good. So what was the first symptom? We did this study a few years ago when I was in Oregon, and we looked at the manifestation of, or the first manifestation of ASG ATTR amyloidosis. And we found that about 50% of people, the first sign is carpal tunnel syndrome. And I think that a lot of patients right now tell me this kind of similar thing. What's important is that if you dig into these symptoms carefully, you notice that a lot of patients actually also have other symptoms at the time of the diagnosis of carpal tunnel surgery, such as GI issue, autonomic, heart disease, or neuropathy. So it's very important to realize this and treat it and kind of address it if that's happening. And the reason is because carpal tunnel syndrome is just common. So a lot of people get carpal tunnel syndrome, especially those with manual, those with manual labor, for example, people who cook, for example, they get a lot of issue with their hand. People who clean houses for a living get this problem as well. But it's much more common in people with ATTR amyloidosis. Something similar to carpal tunnel syndrome, it's the spinal stenosis or lumbar stenosis. You have kind of the same idea where you have deposit of the amyloid in the ligament of the back, and that causes compression of the nerve roots. And when you get that, you get symptoms down your legs with pain, numbness, tingling. The difference between neuropathy, because these can be seen in people with neuropathy, is that when people sit down or lay down, the symptoms get better. Whereas with neuropathy, a lot of time during the day, you're busy, you're not thinking about your feet. And then when you get to lay down at night, you start having pain and burning in the feet. So that's one way to differentiate those two. We also get nerve conduction and EMG, which can differentiate those. and MRI of the spine or CT of the spine can also be helpful in demonstrating this problem. And if you do biopsy the ligament here, a lot of time you're going to find amyloid deposit in the ligament and the tendon that you have biopsied. Another problem that you can get with amyloidosis is that, as I mentioned before, the eye itself makes amyloid, or makes the TTR, which can deposit in the eye and cause some problem, can cause glaucoma, cataract. But one of the things that we also notice is the floaters, and those floaters are not just your typical, something you see once and then you forget about it. It's something that is persistent and can even affect your eye vision. And people, if you remove those, because that's the treatment, if it's affecting the eye, you can remove that floater or that collection of amyloidosis. And when you look under the microscope, you demonstrate that this is just amyloid deposition in the eye. Amyloid can also deposit in the brain. Unfortunately, the brain itself makes amyloid. And I think this is, a lot of experts feel it's going to be a more common problem in the future, because right now people with amyloidosis are living much longer. And we have noticed in people with liver transplant that we see 15 or 20 years later, they start to have these issue with the brain. They can have seizure-like activity, stroke-like activity, bleeding in the brain, because the amyloid is depositing in the blood vessel and in the leptomeninges. And that is also an issue to keep an eye on, especially if you have a lot of high blood pressure or cardiac disease. These are symptoms. They tell you when people start having symptoms with HATTR, for example. I'm not really sure how often it happened in wild type, but in HATTR, usually about 10 to 15 years after the disease onset, you can have these problems, and they can be very difficult to treat. Unfortunately, we don't really have very good treatment right now. Maybe in the future, we'll have a clinical trial looking at a stabilizer, tolcapone, that can penetrate the CNS and treat those patients. We do have imaging for those, kind of similar to what we use in Alzheimer's disease or cerebral amyloid angiopathy with a PET scan, looking at the brain, and we can demonstrate the position of amyloid in some of these patients. Now, how do we detect amyloid? In the neurology world, we still rely a lot on biopsies, muscle, nerve, fat aspirate, salivary gland. If people have GI procedure, we can do that as well. For the cardiologist, it's a little bit easier. They have the PYP scan and PET scan. And if that is positive, and the patient has, for example, genetic mutation, and the SPEP immunofixation free light chain are normal, then in that case, we do have the diagnosis. But otherwise, unfortunately, because there are many reasons why people get neuropathy, we do have to biopsy to prove that this is the reason why people have amyloidosis. So what are the challenges in HATTR? Obviously, misdiagnosis. Hopefully, it's happening less and less these days. There's a lot of awareness. Patients are educating doctors, doctors are educating their colleagues. The pharmaceutical industry is educating a lot of people as well. So hopefully that's not a problem anymore, but we still have delay, unfortunately, in the diagnosis, and we see it on a daily basis in our clinics. People can be diagnosed with a bunch of other things, such as fibromyalgia, irritable bowel disease, CIDP, and so forth. But the progression in amyloidosis neuropathy is usually much quicker, as you can see in this slides here. I think one of the major challenges that I face right now, apart from the CNS and ocular complication, for which we don't really have very good treatment, is the carriers. And people who carry the genetic mutation, but they don't have symptoms yet, and it's very hard to know when the disease is about to start. We can wait until the symptoms have started, but we want to be a little bit proactive and try to detect it very soon, so we can avoid any irreversible nerve damage. And in our patient population at Penn, about 23 and now more probably since I reviewed the data, have unfortunately the TTR variant, but fortunately they don't have symptoms yet. So it's a little bit unclear. Do you give people diflunisal? Do you wait until they get older, when their parents start having symptoms, and so forth? And what do you do? Do you do nerve conduction study? Do you do echo every year? Do you repeat the PYP? There's just no very good guidelines and no study to back up any of those things. So that's get us to the study that we're currently doing at Penn, where we're looking at different ways to detect neuropathy very early in these patients. One way, and this study is supported by Ionis, so I'd like to thank them again, because without them we could not do this study. And we are looking at nerve ending with a novel device that is kind of a microscope that take images of nerve endings, and we can count them. And this we look very distally, whereas nerve conduction study looks more proximally at the nerve. We're also looking at a very promising blood test called neurofilament light chain. And what we've noticing in people who are controlled and just carrier without symptoms, the levels are very low. But if people who develop the disease, even when they're treated, and all of our patients are treated, they have high level of serum neurofilament light chain. So if anybody is living in the area in the Northeast and it's easy for them, or we still looking for 3 symptomatic, so people who have symptoms of neuropathy, and 5 controls, meaning spouse or family members over the age of 60 or 70 without neuropathy, so we can see what normal looks like and what people with neuropathy looks like. So if you are interested, please send me an email, or you can email my research assistant, Dan, or you can talk to Muriel and she can direct you to me. And the study is also compensated, so we compensate you for your time as well. It consists of 2 visits for the symptomatic and 1 visit for the control. So the treatment strategy for hATTR, Dr. Maurer spent a lot of time talking about the specific TTR treatment, but we also don't want to forget that the symptoms, they have their treatment as well, and they can dramatically improve the quality of life of patients. You saw this picture before. We can target the liver by silencing it. Right now we have the RNA interfering drugs such as patisiran and vutrisiran, and ASOs such as inotersen. Maybe in the future we'll have the CRISPR therapy, again targeting the liver. Stabilizer with tafamidis and diflunisal. Tolcapone is the one that can penetrate the central nervous system. And then, the phase 1 with Proteina, we're part of that study, and that is very promising, looking at antibodies that target the amyloid. So hopefully your body can kind of get rid of the amyloid that's already deposited. There's also other trials ongoing that Dr. Maurer mentioned. This is a slide that shows you the progression of disease when you treat people. And if you look at the placebo, which is the red, you see that people continue to progress. So going up is worse in this case, and going down is better. The blue one are people who are treated with a silencer, in this case, patisiran. And you see at the dotted lines here, this is the open label, where people who were on placebo are switched to the drug. And as you can see, they do get better. But what you also notice, they don't get as good as the patient who were treated from the beginning. And that's important. That tells you that there's irreversible nerve and probably other organ damage if you delay treatment. So again, that's why it's very important to detect the disease very early and start treatment when appropriate, and as early as possible. A lot of my patients ask me, how do we know the drug is working? How do we know that it's affecting us? Well, the quality of life, your symptoms, your function, the neurological examination, all of those are important. But we also have blood tests that people have been doing in research. And again, that's the serum neurofilament light chain, which shows you that it drops dramatically in people who are treated versus people who are not treated. So that's what we're also studying. Now it is commercially available, but I don't know how accurate it is, because it's a different method of using it from the one that we use at Penn and a lot of other researchers. And in this study, the Samoa method is very different from one that is available commercially. So if people are interested, I check it commercially, but again, we don't have a lot of data to interpret it, but hopefully in the future, that will be something that will be also useful. Another question we get a lot is, what about combination therapy? You're silencing the TTR protein, but you're not silencing 100%, right? Because we don't really know what happens if you silence it 100%. So there's still about 15-20% of this TTR that is spilled in the blood from the liver, and that the idea is that should we stabilize that with in addition of tafamidis or diflunisal, meaning should we use both patisiran, inotersen, vutrisiran plus diflunisal or tafamidis? And the answer is I don't know. We are currently looking retrospectively our patient population, because about 30% of our people end up on both, not on purpose, but because they see the cardiologist who prescribed tafamidis and they see the neurologist who prescribed the silencer. And but it's also challenging because these are expensive drugs, and if they are not useful, to use both of them, is it really worth it? And maybe we should stick to one. So we don't know the answer, but hopefully in the future we will. In regard to the symptomatic treatment, there's many different medication. We have to be careful. Some of them have side effects that are not really helpful in people with amyloidosis, but know that these are available and you can discuss them with your neurologist. And a lot of time they can make a big difference and impact on your quality of life. So thank you very much. I'll stop here, and I think we're going to take question. Muriel, I'll give you back, and I'm going to stop sharing here.
Thank you so much. That was great. And I do want to mention that both Dr. Maurer and Dr. Karam will be at our October meeting in Chicago, the really big ATTR event that we have. They won't be the only neurologists or the only cardiologists, but we can say this, they'll be the best ones there. Okay. Now with that, I'm going to get in trouble now. Okay, so we do have some questions we want to take, and then we'll take some more later. But and Dr. Karam, you mentioned that you weren't sure about patients that are symptomatic or not symptomatic, whether to put them on diflunisal, because and I was wondering, Dr. Maurer, what do you do when you have a patient that is not symptomatic? They're considered a carrier because they haven't yet, shown symptoms. Do you start them on diflunisal?
Yeah, so I have a discussion with every patient in that particular category. I think the decision making needs to be one of shared thought process. Obviously, taking a medicine for 25 or 30 years when the disease may never, what we call, penetrate or show up, would potentially be a mistake. Having said all that, most people who are variant carriers of a mutation are likely to develop disease. And as Dr. Karam was saying, when they're pretty close to the age of their, what we call proband mother or father who developed disease within 10 years, we think that it makes sense to try to prevent the condition. Diflunisal is usually very, very well tolerated in people who don't have cardiovascular disease. As you know, it's a non-steroidal. It's actually administered at a dose well below that we use to treat pain or non-steroidal inflammatory conditions. Instead of 500 milligrams to start twice a day and escalating, you only need 250 milligrams or half a pill twice a day to stabilize a TTR. In fact, Jeff Kelly showed you probably only need a quarter of a pill or 125 milligrams, maybe 3 times a day. So at that level, the risks of a non-steroidal are pretty minimal. Those risks are, God forbid, fluid overload, high blood pressure, developing an ulcer. We're probably maybe too attentive, but when we do start patients on the therapy at our place, we often ask them to get routine blood tests every few months just to make sure that they're not developing any side effects related to their hemoglobin, their platelets, or their kidney function. So it's an individualized decision. I think it would probably be a little silly if someone, for example, I saw a gentleman yesterday who's 31, carries the Val-122 ILE variant, and the chance of him developing disease in the next 20 years is very small. So subjecting him to a preventive therapy for that long a time period, I'm not sure makes a lot of sense, but we did discuss this, and that's what we do.
Okay, and Dr. Karam, you brought the subject up in your presentation. Do you prescribe diflunisal for those that have not yet presented with symptoms?
Yeah, I think I do exactly the same as Dr. Maurer. So if you have somebody who's 30 and they have V122I, they don't have to worry about this at all for at least 20, 30 years. If ever, who knows? But if you have somebody with V30M, their dad or mom start having symptoms when they were 60 and the patient is 55 and asymptomatic, yeah, I think it's a good idea to take it, honestly. And I've seen people who are older than when their parents have developed the disease, but they've been on diflunisal and they haven't developed symptoms yet. So I see, for example, a 65 or a 70-year-old who their parents they have V30M mutation and they developed the disease when they were in their 50s, and these patients still don't have the disease and they've been on diflunisal for several years, and I think that's probably why. So it is, though, an individual. You have to be careful. At the end of the day, it can cause complication to be on a drug for many years, especially non-steroid anti-inflammatory drugs. So it is really looking at risk factor, what medical condition they have, etc., and then having an individual discussion with each patient and deciding whether to start the treatment or not.
Yeah, I just would parenthetically add, I think sometimes we overplay the risks of diflunisal. I have patients who've been on it for more than 10 years. And to Dr. Karam's point, I'm pretty convinced that we've actually prevented the onset of disease because they're now older than when their parents presented and they have minimal manifestations. So it's definitely a great question, Muriel, and something I think people should consider. One question we have is, what about if you're a wild type patient and you have carpal tunnel years ago? Should we be thinking about it? If you identified amyloid, but those are studies I think that need to be conducted. Similarly, not everyone who has amyloid in their carpal tunnel is going to develop it in their heart. Best data we have is that probably about 1 in 4 might develop amyloid in their heart 10 years later. It comes out of a Finnish study. So prevention is really a great idea, I think, and something we need to think more about.
So you bring up an interesting point. So if someone has wild type because they were diagnosed because of carpal tunnel, but they don't have cardiac symptoms yet, or you do a scan or a biopsy and the heart's okay, and they want to be on something, would you let them be on diflunisal?
Yeah, I have a discussion we're seeing at our place. Our hand surgeons have really systematically now been collecting data. So it's similar. I mean, if someone's 30 and had carpal tunnel surgery, very rare, and had amyloid, I wouldn't rush. But there were individuals who were particularly, the data would suggest penetrance, if you will, or the disease is going to show up more in men. We have a discussion with them. So if someone's, 55 or 60, they may want to pursue this. Now, again, the downside is you might be taking a medicine for something that, who knows, may never show up in the future. So ultimately, we really do need some more robust data. But some patients have opted to try to do something about it, in part because they're concerned. I think diflunisal is pretty well tolerated, is my sense.
Okay, great. I have a neuropathy question for you, Dr. Karam. This person wants to know if difficulties with one's legs is a consequence of amyloidosis. Her spouse often says that his legs feel like they're no longer a part of his body, and he walks with difficulty, and he's unsteady, and he's disturbed in sleep by his legs are tingling and twitching. Are these symptoms common, and are they treatable?
Yeah, definitely. These are symptoms of nerve damage. But as I mentioned, it could be from anywhere in the nervous system. It could be from the nerve roots. So spinal stenosis can give you symptoms like that. Radiculopathy, herniated disc, or amyloid deposition in the back can give you these symptoms. And amyloid deposition in the nerve in the feet can also give you these symptoms. So it does require a workup by a neurologist and at least a nerve conduction study and maybe imaging of the back to determine where the problem is coming from, because the management is different sometimes. And sometimes you can try medications such as gabapentin or Cymbalta, and that can help both with back problem and neuropathy. So a little bit of workup is necessary in that situation to determine the best course of action.
Okay.
Muriel, I just wanted to ask Dr. Karam, I mean, it's my clinical sense that for patients with wild type disease, as focus of today, and maybe in all amyloid TTR, we've oversimplified things. We've always said, do you have a neuropathy or cardiomyopathy? And I think many patients, almost all probably will turn out, or vast majority, have a mixed phenotype. And to your excellent point before, I've noticed more and more that a lot of the autonomic symptoms that really are quite bothersome are really affecting a lot of wild type patients. So I'm just curious if you could comment a little further, given your expertise, about whether we're missing something, whether that's an early marker. And, again, we focus so much on the heart. I'm wondering if we're missing an opportunity to learn more about how the therapies really impact on patients with a very disabling, as you pointed out, part of their syndrome.
Yeah, that's an excellent point. We have, to my surprise, because, for a long time, I did not think that that was the case because I didn't see a lot of wild type. I mean, now, our cardiologists send me more and more the wild type patients. So I have a chance to evaluate them further. And I'm surprised that some of them do have neuropathy that could probably be from amyloidosis. And more important is the people who could have profound autonomic failure and orthostatic hypertension and other symptoms that I personally was not aware that these could be common in people with wild type amyloidosis. And obviously it does complicate treatment because, you have to use medication that may retain salt and water, in people who have heart failure. So that kind of makes things a little bit complicated. But that is definitely something that I think we should investigate more. We do have autonomic testing available. And if not, we can do very basic stuff. And a lot of time, I mentioned orthostatic hypertension is lightheadedness and syncope, but a lot of patients don't know. They get short of breath, for example, but not a lot of lightheadedness, or they get, this kind of headache or neck pain or pressure or fatigue. They feel very fatigued when they stand up. So the symptoms may not be very straightforward. And that's why it's important to kind of investigate these and kind of get an idea how common they are. I totally agree with you.
Okay, thank you. Let's go to our favorite subject, green tea extract. Okay. This person is referencing a study from Heidelberg in 2015. I read about a small trial done by Heidelberg Amyloidosis Center in Germany using green tea extract. The results seemed extremely positive. Have you heard about this trial? And if it was so successful, why wasn't it carried forward?
I can comment. I think prior to the era of proven by randomized clinical trials, disease-modifying therapy such as tafamidis and silencing therapy, we had great hopes for a lot of treatments like green tea, doxycycline, and so forth. My sense of that trial is it was very small. It was in the area of, pre-disease modifying therapy. The effect size was pretty minimal. Green tea is a TTR stabilizer, but in mice, the effect is pretty minimal. And my sense is the amount of green tea you'd have to take is really tremendously high, that these kind of ancillary treatments, I think, are not very useful. They haven't been shown very robustly to do much of anything. That trial wasn't, I think, very impressive, to be frank, and that's a reason why it hasn't led to kind of widespread implementation. So I understand why we were, and I was doing it too, recommending green tea, diflunisal, I think is probably a better treatment. And also doxycycline, we had a lot of hopes for as a therapy that could, detergent out or extract amyloid, but there's now randomized data that suggests it doesn't work, at least in AL amyloid. So I would urge people not to, not take those things, but just make sure you're on something that really has been proven to be effective and not rely on these ancillary therapies. We just don't think they're that effective.
Okay, thank you. Compassionate use. Okay, is it possible for a patient with wild type to get patisiran, ubitrisiran as an off-label or compassionate use basis? seems to be no reason why not, since it is approved for hereditary, says this person. What are your thoughts?
It's a great question. Compassionate use is, a complicated process. My understanding at this point is that we can maybe hear from the sponsors of these products, but their ability, a provider could request compassionate use, but their ability to provide it would be very difficult, and I'm not sure where it would end. The FDA hasn't approved the therapy, so I guess compassionate use is using it currently off-label without insurance approval. I can tell you that to try to do that in an individual center requires institutional review board approval. You'd have to write, an IRB. Ethically, I would say I support the idea, but I don't know where I would stop. I have, 800 people on tafamidis. If they all wanted patisiran, how would I, I couldn't write an IRB for each of them, so to have to write an IRB for everyone, how would I pick? But I think the underlying tenet of that question is appropriate. We really do believe that these therapies work across the spectrum of disease. So if I had one thing to criticize us, that is the experts on, I think we made a mistake years ago at separating the disease into wild type and variant, neuropathy and cardiomyopathy. Biologically, they all work the same way. And kind of wish we figured that out early on and did trials a lot faster and quicker. On the positive side, patisiran's been submitted to the FDA. It's under review, and maybe I'm too bullish, but it's been on the market for many years. It makes a lot of sense. The trial that I presented, Apollo B, was positive, so I think it's going to be in patients' and clinicians' hands very soon. So hold on, is my hope for whoever asked that question. But I understand the motivation.
Okay, so in other words, do away with the terms FAP and FAC. If you had it to do over again, there wouldn't be any separation between the two.
Yeah, I think, to be honest, that grew out of, as Dr. Karam was saying, clinical experience. If you're a cardiologist looking at a patient and trying to examine their nerves, I do a pretty terrible job, and I can't really figure out that they have a neuropathy. But if I send that same patient with wild type disease to Dr. Karam, he does a fantastic job and can tell me, wow, there is really. So that's part of it. And then there are regulatory reasons, right? Our regulators who approve drugs, they're great and they're wonderful and they make things safe, but they're silos. So they have a neurology division, a cardiology division. So, there are a lot of hurdles to all that, but I just wish we got drugs into hands of patients as fast as possible. And I acknowledge we're not doing as good a job as we could, but I apologize.
Okay, that's okay. We accept your apology. Devices for heart rhythms. I was diagnosed with ATTR wild type 3 years ago. I had a pacemaker, CRT-P, installed shortly after diagnosis. As my electrocardiologist explained, that heart rhythm problems were a normal side effect of ATTR, and he strongly believed it was a good proactive measure to take. He recently experienced his first instance of heart flutter, which was successfully converted using cardioversion. He's now on a daily blood thinner to avoid blood clots if and when his irregular rhythm reoccurs. So his question, is there any medical intervention, device, surgery, medication, etc., that can lessen the likelihood of future heart rhythm problems for ATTR patients? He's on Vyndamax.
A really fantastic question, and a lot of things to just talk about in there before we get to the question at hand. So arrhythmias, because amyloid gets not only into the muscle, but also into the electrical wires inside the heart, are very, very, very common. So the most common sustained arrhythmia that people have is atrial fibrillation. At least a third of patients at diagnosis, and in many centers it's upwards of 50%, have AFib when they first come. And my clinical experience is that almost 90% of patients over their lifespan will develop atrial fibrillation. Atrial fibrillation is when the top part of the heart, it's the atrium, is supposed to beat in a coordinated fashion, boom, boom, into the bottom part. Fibrillation is a Latin word. It means dancing. And so the heart top part is not beating like this, but just wiggling. And because the heart wiggles and doesn't completely contract, the blood stagnates inside the chamber, and a blood clot inside the chamber could form. And God forbid, a blood clot could travel and cause a stroke. So anyone with amyloid heart disease who has atrial fibrillation detected on an EKG or on a monitoring device needs to be on a blood thinner, irrespective of how long the episode was or whether it was symptomatic or asymptomatic, because the risk of a stroke is high enough and the stroke is so devastating. So I'm glad to hear that that individual was placed on a blood thinner when they had their AFib detected, presumably on interrogation of their pacemaker. The other thing that's common is conduction disease, so slow heart rates that require a pacemaker. There's emerging data to show that somewhere between 10 and 40% of patients, now that people are living a lot longer with TTR cardiac amyloid, will require a pacemaker. So a lot of people are going to need a pacemaker. Unfortunately, it doesn't seem, we don't know completely, but it doesn't seem like the drugs that we're using are doing much to ameliorate the need for a pacemaker. I don't know if that's completely true, but I can tell you that in the trials that have been conducted, there haven't been subgroups that are reported that says those who got the drug had a lower chance of getting a pacemaker or a lower chance of developing AFib. Maybe that's because the companies haven't looked, but I think they probably have, and the data suggests that it doesn't change that outcome. The other part of this that's really important, I think, and I mentioned before we joined the call, a few people, is that, you know, most people who get a pacemaker because of a slow heart rate get a pacemaker that's placed in the tip of the right ventricle called an RV pacemaker. That's the standard one. And that paces the heart in an unusual and not normal manner, in which the heart, instead of both walls beating together synchronously like a normal heart, the right wall moves first and then the left wall. So your heart kind of beats in a discoordinated manner with a pacemaker. And that could make the stroke volume, that's the amount of blood the heart's pumping that I showed you that was low in an amyloid patient, even lower. And so this patient describes that they got a biventricular pacemaker. That is, you know, I don't know what we call the best car nowadays, Cadillac, Tesla, whatever your term, but that's we think the best form of a pacemaker. It requires an extra lead to be placed in the heart so that when you pace the heart, both walls move together. And we think at our center, and many others, I think in the amyloid community, think that's the right type of pacemaker. Unfortunately, it's often not covered by insurance. And so, you know, we're hoping with NIH's support to maybe launch a study in which we would give every patient in the study the Cadillac or Tesla, but test whether or not one form of pacing for a brief period of time is better than another, but everyone would have the Cadillac to go back to. But I think that makes a lot of sense. So these arrhythmogenic issues, AFib, you know, slow heart rates needing a pacemaker are very common. I think it's one of the consequences of our success that people are living longer with this condition. And it's something that really requires expert management. And I think it's something about the new horizon that we're going to be facing. Hope that's answering the question. Unfortunately, I don't think, to summarize, that the drugs really prevent those arrhythmia issues.
Very good. Thank you. Okay, Dr. Karam, I think this one is for you. It's in regards to phlegm. Okay. In your experience, do you have any patients who have constant phlegm? And if so, how do you handle the situation?
Yeah, that's a good question. We do have, you know, that's a, maybe Dr. Maurer can actually maybe comment on that too with, I mean, the cough and the phlegm itself is not the issue. I think the chronic cough that some people have can be a problem. I don't know, Matt, if you want to comment on that or. Yeah,
I mean, it's been my clinical observation, and patients have expressed this, that there's a huge number, you know, 30, 40, 50% who complain of what we call rhinorrhea, which is a runny nose all the time. You know, they keep needing to wipe. They have, you know, plethora in their face. And I don't know the answer, but I can give you a hypothesis. And that is, when your heart is leathery and thick, it doesn't not only deliver amount of blood, but the blood backs up. And so a patient with amyloid, we always look at their neck vein, that is the jugular vein, that's kind of sticking out, because like a pump in your basement, not to be too colloquial, right? When it doesn't work, the water backs up in the corner. And this is the corner that we look at. Those high pressures cause high pressure in the face veins. And I think it leads to essentially generation of a lot of fluid. And so often I see this more in patients who have pretty high filling pressures inside their heart. We try to adjust their medicines. Sometimes more diuretics can help. And as I mentioned, those drugs, the SGLT2 antagonists, might be something that someone wants to consider. I don't know if it'll decrease, but it is a very, very, very common concern and complaint among patients. And to be frank, we don't have a great deal that we know of specifically how to treat it. But as I'm indicating, I'm not sure we even know what it's caused by. If my hypothesis is correct, that it's due to this engorgement of the veins, how do we lower the pressures a little bit? That might help.
Okay. Okay, here we have a lot of neuropathy questions. He's 76 years old. Okay, he was diagnosed in 2019. Okay, and he's on Ionis. Okay, when his Ionis trial is over in 8 weeks, should I continue with the tafamidis stabilizer in addition to being on the Ionis silencer? I believe that there is efficacy for being on both. Now, this is a wild type person. Okay, so this isn't a neuropathy question, but he has a lot of others. But so you were. Dr. Karam, I believe you spoke in your presentation about taking 2 drugs. What is your thought on being on both the Ionis drug and the tafamidis stabilizer?
Yeah, so I mean, as I mentioned, a lot of our patients, about 30 to 40% end up being on both. We just don't know if it's superior to being on one of or the other, honestly. You know, from if you're going to think about it, you know, the silencer is reducing the production of the TTR protein by the liver. You still have a few TTR protein that are being secreted in the bloodstream, and the stabilizer could potentially stabilize those leftover protein and makes things better. But that's in theory, you know, unless you have a good data and a study that showed that people may be taking more medication than they require. Now, the question is, could a silencer be better than a stabilizer? And that's a completely different question. And again, I don't think we have a very good answer. From the neuropathy perspective, I do think that that is the case. I think that it's hard to compare the trials because they were not head-to-head, but just looking at things and looking at the efficacy of treatment, I do suspect that silencer are probably better. But in regard for the cardiac, I don't really know. So I'll let maybe Dr. Maurer comment on that. But if the patient, I think, has the opportunity to be on both, I don't think it's a bad thing.
Yeah, I would agree. I would point out that congrats to this person. I think they're reaping the benefits of enrolling in a clinical trial, right? Because this person, presumably in the CardioTransform trial, they're, ideally, hopefully receiving active therapy. But even if they're not, when the trials are over, they get active drug and they get it for no cost. And so they can get their tafamidis through their insurance, and they can get a silencer through the study. And here you see, I think, the practical benefits of not having to worry, who's going to pay for it, what's going to happen. So I appreciate their participation. It helps them. I hope it helps lots of other people. I would point out that in other forms of amyloid, AA and AL, we know that if you get rid of the precursor protein, right, you knock it down with either chemotherapy or anti-inflammatory therapy, that is the key to successful outcomes. So if you're a believer, which I am, as I think Dr. Karam was saying, in knocking down or silencing the protein, and you take the data from AL and AA, knockdown or silencing should be highly successful. So which will be better? I agree. I think probably silencer may be better. We don't know about combination therapy. In the absence of a cost issue, I think it would be perfectly fine. The one concern I say to my patients, I get very worried about this because insurance sometimes can dictate. At this point, I haven't seen a lot of what they call tiered therapies, but I worry if I prescribe both. Some insurance companies have come up with a tier that suggests that the cheaper one is the one they want me to give, which may not be the better one. And so, just be cautious. I hate to tell people that, but sometimes when you try to get on 2 therapies, you could end up getting, as my grandmother used to say, stupped, not by an insurance
Wow.
company.
Okay.
So that's me just being a paranoid Jewish guy in New York. But
we'll have to bleep that. Okay. Is that okay?
Yeah, no. So, but it does physiologically make sense. And the question also is, if you have very little going around, do you need a expensive stabilizer, or could you get away with diflunisal? Who knows? But those are very important unanswered questions.
Well, you bring up the point. In AL amyloidosis, if they stop the factory where the amyloidosis is made, that gives the organs, if they're not being pelted with amyloid, a chance to heal themselves. So what you're saying is there's a possibility, although we don't know, that in TTR, if we stabilize the TTR or stop the TTR from being made, and we stop pelting the heart and the nerves, maybe they'll have a chance to heal themselves, which is pretty exciting to think about for sure. Yeah, okay, we're with that. Okay, So this person has wild type. We were discussing this briefly, and he's developed neuropathy in his feet. And he wants you to explain he uses the term nexus between ATTR and neuropathy, and what are the latest treatments for the condition. He's been taking natural supplements, but he still gets stingers and the feeling that he's walking on water blisters.
Yeah, so one thing that it's important to know in the neuropathy is that once you damage the nerve, you can be left with symptoms, even if the underlying disease is controlled. So for example, if you have already neuropathy and it's caused by the amyloid, and you stop the amyloid, or you significantly slow down the progression of the amyloidosis, and there's no more loss of sensation and weakness and dysautonomia, etc., or these are stable, people may still from time to time have the worsening of their symptoms from the neuropathy, from either because the nerve have been damaged and they just act up and they just send an abnormal signal to the brain telling them, hey, there's something wrong, when there's really nothing wrong. And the other thing that I always try to educate our trainees is that, people there's hundreds of reasons why people get neuropathy. So people can have amyloid and they can develop diabetes, or they can have vitamin deficiency that's very easily treatable. So the two things that we usually try to do is, one, make sure there's no other reason why people have neuropathy on top of the amyloidosis. And two, we can try to control their symptoms with the medication that I mentioned before, such as gabapentin or duloxetine, and these kind of decrease that stinging and burning sensation as well. Now, natural supplements, people take them all the time. We cannot say much about those because there has not been any study that looked at whether people who taking the supplements versus those who were not have any impact on the neuropathy. The one that has been studied, actually, the alpha lipoic acid, which is commonly taken, did not really have any very good evidence that it's helpful in people who have diabetes or chemotherapy-induced neuropathy, for example. So we're not really sure. If people want to take it, great. They can take it. Usually they have little side effects. But for the other one, I would be careful, because sometimes you may think you're doing a good thing, and that supplement may actually not be a very good thing to you. So I would be extremely careful with supplements. A good example is, for example, vitamin B6, which we know if people take in very high quantity, by itself can cause nerve damage. So I would be careful with the supplements. I would discuss them with the doctor, have them take a look at them and decide. But for the stinging, even if the disease is controlled, they may still have some stinging and burning sensation, and they can, if it's affecting their quality of life and sleep, then they can request some medication from their physicians.
Okay, nitric oxide to enhance blood flow.
Mm-hmm. Nitric.
What do we know about that?
Yes, nitric oxide is a substance that actually someone won the Nobel Prize for discovering, or nitrous oxide. It dilates blood vessels. You may recall there are drugs called nitrites or nitrates that are, medicines to treat angina, for example, that relax blood vessels. There are also nitrites in foods. So beet juice extract, for example, has a lot of nitrites, and there have been studies in patients not with amyloid, but with heart failure and a preserved ejection fraction, that it might relax the blood vessels and therefore make it easier for the heart to pump and improve how people feel. So similar, not a lot of great evidence or data. These are kind of natural supplements. I don't think they're harmful, but I don't think we have a lot of information that they're very, very, very useful in patients. So back to the basic principles, I have no objection to you thinking about them, but make sure you're on some proven and standard therapies before you go into, other that might help you functionally, but haven't been proven.
Beet juice, so maybe people that have a lot of borscht, that might help them?
Yeah, there's been studies with, again, there are actually formulations online you can find. There's probably back to the green tea, you need to drink enough green tea to become green, literally. Same with beet juice. I probably think you might get fed up with the borscht, so you may want to just find it in a different formulation.
Okay, we've got this question in various forms throughout. Okay, it's kind of like the question, how do I know I'm improving if I'm on treatment? And some people say, should I have another PYP scan? Should I have another blood test for my transthyretin TTR. I mean, how, if a person's on tafamidis or on Patro or on Tegsedi, how do, outside of the fact that they may or may not be feeling worse, but not necessarily feeling better, how else would they know that they're improving? Is there a way to measure? I know there's no biomarkers, but is there something that they can see in black and white that will show them that they should be improving in some way?
Yeah, this is a very, very, very important question. How do we monitor disease? And how do we monitor disease actually in the era, God willing, of multiple different therapies, not only to inform the patient better, but to select what the right treatment is and choose amongst them. And we don't really know, to be honest. This requires a lot more work. Back to your point, first thing is always you just talk to the patient. They usually know how they're doing. We use things like New York Heart Class, which is a rating of what you're able to do functionally. We can do performance measures. So at our center, we try to indoctrinate the 6-minute hall walk-in to be a judge of how well people are doing. That doesn't need to be measured every day. Once every 6 months or a year is perfectly fine usually. We've learned a little bit about a performance measure that we're studying called the Short Physical Performance Battery. It's called the SPBP. It's a scale that we're enamored by at our center. I think it'll be very useful. It involves 3 different measurements. Gait speed, that is how fast you walk in meters per second. Turns out to cross the street in Manhattan and not get hit by a cab. You may recall the lights are set up in a certain way. You need to walk 1.2 meters per second. So I jokingly say most of my patients who have a cane crossing Broadway and can't make it across, they use that to make sure the cab they wave it at doesn't run them over. But many patients with amyloid, unfortunately, if they have advanced disease, will walk 0.8 meters per second or less. That can be measured in an exam room. You just ask the patient to walk, 5 or 10 meters and put a stopwatch on and see how their speed is. That's rated 0 to 4 in this scale. You can get 4 points if you walk quickly and less if you walk slowly. Second thing we do is we do a balance. We ask them to put their feet together and hold it for 10 seconds. If they can do that, we ask them to put one foot juxtaposed next to another. If they can hold that for 10 seconds, we ask them to put one foot in front of the other and hold that for 10 seconds. And they do all of those, they get all 4 points. They can do less than, all those maneuvers, they get less points. And the last thing we do is chair stands. We're in a stable chair in the room without wheels. We ask them to fold their arms and try to stand up and sit down. And if someone can stand up and sit down and do 5 and 11 seconds, you get all 4 points. So the scale goes from 0 to 12, very simple. Can be done in 5 or 6 minutes. We have a coordinator in our program who tries to do that frequently on patients every 6 months. And it's a scale that if it changes by a half a point, that's considered clinically meaningful. So we have a lot of good data about that. Second thing we do, third thing we do besides functional measures, we measure quality of life scales. We've been able to, and I appreciate our patients participating, figure out a way to email them questionnaires at a set time interval. They can get them on their phone or their computers and answer questions like we were used in clinical trials. And every 6 months we ask them, we get about 75% of our patients who respond to those and answer the questionnaires are automatically scored. And so we can track how their quality of life is, their autonomic nervous system. We heard about there's a scale called Compass. Blood tests do work pretty well in tracking this disease. So there are cardiac biomarkers. We don't have a light chain like we do for AL amyloid, but NT-proBNP and troponin we measure every 6 months, and we measure pre-albumin or TTR levels. They go up in people who take stabilizers like tafamidis or diflunisal, and they go down in people who take silencers. And so we show our patients those values because everyone wants to know, is the drug working? And those are kind of surrogates for that. So those are some of the ways. Which is the best way? I have no idea. Are they all necessary? I don't know. Or is there overlap? These are things where we really need patients to actively participate. We'd love to hear, what's the easiest way? What's the least burdensome? The beauty of this condition is the patients, as you know, Muriel, are absolutely lovely and so engaged that we'll be able to figure, I think, this out pretty quickly about what the right way is to follow patients. But those are some ways that we've been trying ourselves.
Thank you. Before we take our break, I do want to mention that we did invite a trellis to this event, and they usually show up, either Dr. Wall or Spencer Guthrie, but neither one could make it today, unfortunately. But most of our people now know about the imaging that they're doing. Do you see that the future of imaging and maybe measuring how people are doing? Do you think that
Absolutely. We actually started a pilot study at Columbia, and 25 people it's only cross-sectional, so we're just doing one scan. We're actually using it because while PYP scanning is good, it's not perfect, by the way. It's at best hands 90% sensitive. That means it misses 10% of the people who have cardiac involvement, and probably is even less sensitive than that. So we think there are people who are being missed because PYP scans are negative. That's one group we're studying. And we're also studying people who we know have extracardiac disease, either lumbar spinal disease or carpal tunnel or some other organ involvement. And the final group that we're studying is people who have unusual variants where PYP is negative. And so far, the scan performs fantastically. And anyone who we have a biopsy proof of amyloid and for example, their PYP is negative, the scan is positive. And the future, I think, is exactly what you're describing, that if you can measure the quote unquote amyloid load, where it is in the body and how much of it is, and quantify it, then over time, I don't know what interval that will be. Will it be a year, 6 months, 2 years? You could track how someone is doing. So I think sophisticated imaging with MRI and PET scanning holds great hope for the future, and very excited about participating in such programs.
Okay, great, thank you. What's going to happen next is we're going to take a 10-minute break, and then we're going to continue with Paula and our pharma, and then after that we're going to continue with Q&A with our doctors. So Dr. Karam and Dr. Maurer, I do want to tell you that because we'll be doing pharma after the financial assistance and the break, you can leave for half an hour and go have some lunch. How's that? And for the rest of us, we're going to take a 10-minute break, and then we'll be back to hear from Paula and Pharma, and then more questions from our esteemed doctors. Okay? Welcome back, everyone. Okay. I just want to give a little quickie reminder, okay, that we, and you can check the link on our website, amyloidosissupport.org. A reminder of our October meeting in Chicago. This is a meeting we've had every other year since 2009 for our ATTR, both hereditary and wild type. The very first year, 2009, I think we had 85 people fly into Chicago. And at our last meeting, we had 450 people in 2019. So we're thinking maybe we'll have 400 or 450. We don't really know how many that we'll have at the meeting in October. All the food is free. It's a 3-day event. So the only thing that you have to save your pennies for is the hotel and your airfare. Okay. And if you don't have the financial resources, you send me an email and we'll see if we can't get some help for you. So my email is Muriel at amyloidosissupport.org. So know that we're here for you, and we don't want money keeping you away from this event. It's really important that all of our ATTR patients come to this event. We have the who's who of the amyloidosis doctors. You've met many of them at our webinars, and there's even more. And we have Monica Fozzie Bryant, who will be helping you out with Medicare and insurance questions. I cannot tell you how life-altering some of these meetings have been for many of our patients. So we really hope that you can all make it. Okay, Paula, are you ready to share with us some information about financial assistance?
Hello again, everybody. And we've heard from our doctors about the medicines that we've got as are available to you now. And we do all know, unfortunately, that they are very expensive. So we're going to talk a little bit about that. But to start with, I'm going to mention something that has not really been brought up yet, and that is genetic testing. If Bob, you could move the slide one, please. There is free genetic testing available for those of you that may not know that, for your family members that you think may have the possibility of having hereditary TTR. You can contact either one of those, go to either one of these links that are shown on the screen, and I have already put this information in the chat as well. If you go to the bottom of your screen, you will see the chat window down there. If you click on that, It will show up on the right-hand side of your screen. You can also save the chat by going down to the bottom where it shows where you can type a message. If you look to the right, you'll see 3 little dots. And if you click on those dots, the top thing is save chat. So you can click on that and save the entire chat information from today's webinar to your computer. You just need to note where you are saving it on your computer so you can go back and find it. But if you go to either one of these links, you can read about how to go about getting this testing set up. If your doctor's office does not do it for you, you can implement it on your own. You don't have to have them, but it's helpful if you do have them. So just keep in mind that this is free and it is out there and available to you. Next slide. Now we're going to talk a little bit about the money and how you go about trying to find assistance. You can do it. Each one of our drug companies has an assistance program set up for you. You can go to their websites and get connected with a patient liaison. They have different names for them depending on the drug company, but it's all basically the same thing. These people are there to help you. They will help you navigate through the process of getting set up for your drug, and also to see if you qualify for possibly free drugs through their foundation side, which would be another area that you would have to contact, or they would put you in contact with. But just know that these people are there to help you. Utilize them. That's what they're there for. Don't think you're going to waste their time by contacting them. It is their job. They will be more than happy to assist you. These links are in the chat, so you can access them later if you need to. Next slide, please. The private foundations, they're 501c3s that are set up. These are 3 of the top ones that have been known to give out funds in the past to amyloid patients to help with the copays on these drugs. For those of you that are on Patro or any infusion drug, that is covered under Part B on your Medicare, and your copay assistance, your supplemental policy picks up the remainder of what you would owe. But for those that are on a pill form, and in some cases the injectable form, which right now we're trying to get that straightened out, where some of these insurance companies are putting Ambutra on Part D when it's supposed to be Part B. But there again, that's where you need to contact the drug companies, to those liaisons, to get them to help you out with this. But these foundations have money available throughout the year, off and on, as funding is available for you to get signed up with. So far, Healthwell Foundation has been open this year for patients that were renewing grants that they had last year. I have not seen where they've opened up to patients that are new yet. But since we are in the new year, hopefully all of these will be opening up soon, but we never know when they're going to do that. So some of these have a waiting list. Go to these websites and sign up for this waiting list, and you will receive an email when it opens back up. It's important to jump on this as quickly as you can when you get an email that says these funds are available, because they go very quickly. There's a lot of people out there. It's a lot of competition for these funds. If you miss one funding cycle, it may open back up in a month or so, or 2 months or 3 months. We never know how it's going to open up. So you've got to stay on top of this if you are needing a grant, so you can help afford these drugs on a monthly basis. So just know, have all your stuff ready, have your tax forms where you can access them quickly if you need to be able to give that information to these organizations. You want to have your ducks in a row beforehand if possible. So just know that, and try to keep an eye out to your emails to see if these open up. Next slide. This will give you an idea of the amount of money you can make each year and still qualify for these programs. Some of them have different thresholds that you have to fall under to be able to qualify it. Most of them are the 400 or the 500% category. And you go by the left-hand column over there with how many people you have in your household, and you can see the amount. Now, that does vary somewhat depending on where you live. If you are in a large metropolitan area where the cost of living is higher, they do adjust somewhat for that. So don't take this completely as fact that, you know, oh, well, I make $98,700, I won't qualify. Call them, get in contact with them, and try it anyway, because there may be an adjustment for where you live. So, you know, do apply, even though you may not know if you qualify or not. They may work with you on some things. So just always talk to these people. Don't take it at face value. Next slide. This is another way to find out when funds open. You can sign up for this fund finder that the PAN Foundation has. It will email you when funds open up as well. It may be delayed somewhat as the emails you would get if you sign up directly with each foundation. I believe you'll get those quicker than what you get this, because, you know, they have to have time to go through and adjust their website once it opens up. But this is a backup to it. This is a sample of it on the screen. This has a Leukemia and Lymphoma Society with a green unlocked lock on it. That shows that that fund was open, but that was for AL amyloidosis, unfortunately. But that shows you how their screen will appear. And if it's got a red lock, that fund is closed at that moment. But if it's a green padlock that's unlocked, then that fund is open. So you can, you know, go ahead and try to apply for that funding. Next screen, or that is the last screen, I do believe. Yes. But so that's it. But just know that there is assistance out there. It may not be open right when you need it, but be persistent and keep an eye on it, and you may qualify for it sometime throughout the year. But generally once we're past, say, August, going on past years and what they've done, they may not open right back up until the next year. So once you get into the August, September, October ranges, they're probably going to be closed for the rest of the year due to lack of funding. So be quick. That's all I can tell you, folks.
Thank you, Paula. That is so helpful. And if anyone has any further questions, you can email Paula at amyloidosissupport.org. She keeps track of these things for us, and we really, really appreciate it. Thank you so much. Okay, now we're going to hear from our pharma peeps, okay? And we appreciate everyone giving us this day, but we're gonna, you know, pharma, we're running behind, but anyone that's ever taken part in one of our webinars knows that we've never not run behind. But with that said, we're gonna be very firm and use a hook if you go over 5 minutes. So keep that in mind, but we will have Q&A afterwards with the doctors and with you. And we do have some questions for our pharma as well. So next we'll hear from Jocelyn Ashford from Bridge Bio. Okay, there she is. Hi there.
Hello, everyone. How are you, Muriel? I am so excited to be here. Happy Saturday, everyone. My name is Jocelyn Ashford. I am the Vice President of Patient Advocacy at Bridge Bio. And I am excited to just share with you a little bit about Bridge Bio in my little 5 minutes. So first of all, some of you may or may not have heard of Bridge Bio. We are a company that's focused on developing medicines for conditions that are genetically driven and cancers with genetic drivers. So ATTR is one of those conditions that we work in. You actually heard a little bit about the molecule or drug, investigational drug that we're working on, acoramidis, from Dr. Moore a little bit earlier in the presentation. So I don't have any data updates for you, but what I just want to make sure you know is that BridgeBio is working on acoramidis. We're in the middle of our phase 3 clinical trial called ATTRibute-CM. You can learn more about that on clinicaltrials.gov. And we expect our data for this 30-month study to come out in July. So you're going to hear a lot from us when the data comes out in July. And if you have questions about the molecule or about the study, you can obviously ask your doctor, or you can reach out to us at medinfo@bridgebio.com. And again, my name is Jocelyn. If you attend the Chicago meeting this fall, you'll definitely see me there. Thanks, Muriel.
Thank you, Jocelyn. I can't remember if it was Dr. Karam or Dr. Maurer referred to your drug as super tafamidis or whatever.
Yeah.
So needless to say, we're all anxious to hear, I guess it'll be in October, how super it really is, right?
I can't wait to find out how super it might be. So
There you go.
yeah, Dr. Moore was very generous in his words.
Super. Okay, thank you. Okay, next we will hear from our friends at Pfizer, and Craig's been a friend for a long time. So Craig at Pfizer, take it away.
Great. Hi, everyone. Great to be here. Craig Spolsky, Advocacy and Professional Relations Director with Pfizer. I am going to share my screen with you right now. And I'm excited to be able to kind of share info on a new website that was recently launched. The website is called togetherforrare.com, and it's a resource for patients and caregivers. Togetherforrare.com replaces an online form that you may be familiar with called PfizerPal.com. So on togetherforrare.com, you're going to find a short video. Actually, I'm just going to scroll down here. So into the center of the homepage, if you click here, it will lead you to a short video which describes the role of our Pfizer Patient Affairs Liaisons, or PALs for short. And it describes how they support the advocacy community, patients, and caregivers. Now, PALs work with patients and advocacy groups to better understand the needs of rare disease communities. They also provide educational information on Pfizer programs, serves as a contact for local patient advocacy groups, and can answer questions from patients and caregivers about certain programs available to them. If you're interested in connecting with a PAL, actually, I'm just scrolling up here. You would just simply click on Get Started, which will take you to an opt-in form. And there you'll be able to fill out the form and connect with a Pfizer Patient Affairs Liaison specific to your geographic location. Once you fill out the form, they could contact you, discuss resources and information relevant to ATTR-CM, and Pfizer may email you with educational information about ATTR-CM, as well as information relevant to living with a rare disease generally. If you'd like to connect with a PAL, you have several options to do so. When that time comes, you connect with them via email or over the phone or via Zoom, whichever option is most convenient for you. Also on this website, you'll find a list of resources, which I'm going to go to right now. So if you click the tab for ATTR-CM, you'll see a number of ATTR-CM disease downloads, digital downloads. There's also a website to a link, Your Heart's Message, which is that first listing right here. You'll find information here about ATTR-CM. You also find a really helpful doctor discussion guide, as well as educational resources. And if you scroll to the bottom, there's also a digital download here that describes the PAL role, as well as a call to action around Together for Rare. So this is something that a patient could print out and provide to their caregiver, or caregiver could provide to the family to better educate them around this resource. So if visiting Together for Rare is of interest, I'd suggest a good starting place is the home page and really clicking this video, which is under 3 minutes, to really get an understanding of how the PALs can support you. And then if interested, you could take the next step and opt in so you could connect with a Pfizer PAL. Muriel, thanks for the opportunity as always, and handing it back to you.
Thank you. Don't disappear, because I want to ask you a question. If I am a patient and I am having a problem getting my, because it's a new year, getting my Pfizer drug, or getting my financial aid from Pfizer that I qualified for from last year, and I'm having a problem getting it, would I go to this Pfizer PAL person? Is this who I would go to?
Yeah, so I would provide a different resource to go to because it's a very specific request that you brought up, Muriel, and I would suggest going to vindalink.com. So VYNDA link, LINK.com, where you could find information, or I could provide the phone number and also could provide it in the chat. But the phone number for Vindalink is 1-888-222-8475. And folks are available Monday through Friday, 8 a.m. to 8 p.m. Eastern time.
We'll put that in the chat.
Yeah.
Paula will do that for us, I hope. Thank you, Paula. Now, let's say Vindalink did not call me back. What's going on here? What's my next step? I mean, I've got 5 pills left. I'm running out. Help.
Right, sure. Definitely make another attempt. We always try to call folks back in a timely fashion. So call back to Vindalink. If not, folks can always reach out to Muriel, and Muriel can reach out to me, and I can make sure that that individual request is escalated. But I would always go back to Vindalink and try to connect with the folks that support your case there.
Okay. You heard it from Craig. Okay, the horse's mouth. You're now the horse's mouth, Craig. Okay.
Thanks.
Okay. Thank you, Craig, and thank you to everyone. We really appreciate it. And if we can have everyone back now, and our doctors, of course, because we have more questions. And we have a half hour to get them answered, and I know I promised everyone we'd get them answered. So I'm going to ask everyone to please, I'll send you via email the ones that don't get answered so that we do get answers, because I promised and I don't want to be a liar. Okay. Life expectation. After treatment on Patro, I'm tired for 2 days after my treatment. What is the life, I don't know how this relates to on Patro, but maybe it's a good one for everyone. What is the life expectation of this disease? If you're on treatment, I mean, do we, that's kind of a difficult question, but I'll throw it out to you, Dr. Maurer, and then we'll see what happens.
Yeah, well, we anticipate certainly that, and the evidence supports this, that patients on treatment will live longer, feel better, and function better. For an individual patient, I know this is sometimes an appropriate concern. That is, hey, doc, how am I doing and how long do I have? We should clearly state that doctors' ability and all healthcare providers' ability to predict one's lifespan is pretty terrible. There are, staging systems that have been developed that indicate based on certain blood tests. I mentioned before your New York Heart class, and also how much diuretic you're taking, that can essentially identify how severely affected your body is in this realm of wild type transthyretin and cardiac amyloid. And so providers can give you an estimate of how people in general in that group do, but certainly we're not able to easily predict one's prognosis.
Okay, this is a question for.
Can I make an observation here?
Go ahead, please.
Regarding the fatigue after Onpattro. So, on Patro, the way we prescribe it initially, there's you give people steroids and an antihistamine, among other things, to prevent infusion-related reactions. And those have, I think, a lot of the side effects that people experience are from these medications. So, Benadryl makes people sleepy and tired. Steroids can give you mood change and other problems. Sometimes can give you a boost of energy, so people feel good the day of the infusion. But I think one thing to realize is that people don't need to stay on these medication for the rest of their lives. So basically, if they tolerate the drug well, they tolerate Onpattro well, a lot of time what I try to do is reduce the dose of steroids and Benadryl. And eventually, a lot of my patients are not on it. So these can give you side effects. And if you stop them, a lot of time people don't have side effects. So that could be a contributor to the fatigue that people are experiencing.
Yeah, I'd just add, I think it's a great point. We also have been using non-sedating antihistamines. So Cetirizine orally is probably better tolerated, for example, than Benadryl for patients who require pre-medications.
Okay. Now I would imagine though, when with an Amvuttra, which is Onpatro's, big cousin, that you don't need all those pre-meds. Is that correct? Or
Correct.
okay, great. Hey, Dr. Maurer, this person wants to know if Amvuttra or patisiran is approved for cardiac, would you prescribe tafamidis or one of those drugs?
It's a great question. I think we have to wait and see what the data show in order to know. Obviously, we try to prescribe the drug that we think, or combination we think, has the greatest benefit for patients. Unfortunately, I think providers and patients are going to be in a difficult circumstance because these therapies haven't been tested one versus another. They're all tested against, at this point, a placebo group. And thankfully, we've made great strides in identifying people much earlier in the course of the illness. So I would tell you, comparing patients who are being treated today with patients who were treated in 2013 in the ATTR ACT trial, who are much, much sicker than I think many of the patients we're seeing today, could be very difficult. So hopefully some of the larger studies and even the ones that are being conducted will have comparisons because they allow people on tafamidis and we may get some inklings of those things. But as I think we were describing before, we're going to potentially be in a very uncertain circumstance. So we'll have to see if we're right. Some of us do believe that silencers may be more effective than stabilizers, and maybe the data will show that. Then it'll be a clear path forward about what should be administered when.
Thank you. All right, Dr. Karam, this person was losing all muscle tone and now getting strong pain, some strength. They've had one Amvuttra infusion. Is this explainable?
Yeah, that's not a very clear question, because were they on any other treatment before, or did they just start Amvuttra? If they just started Amvuttra, you don't expect to have a dramatic stabilization or improvement in their symptoms right away. I mean, remember, these things take time. So usually I tell people you need to be on treatment for at least 6 to 9 months to start seeing a difference. But at the same time, the symptoms of the disease, such as pain, etc., can be treated with other medication that can control pain. So maybe people can clarify what they meant when they are on Amvuttra for just one infusion. But I don't, we don't really expect dramatic change in people's symptoms just from one treatment.
Thank you. This patient says that her physician suggested a spinal cord stimulator for neuropathy. She's presently on Amvuttra, and she takes Lyrica and gets very little relief from that. So what are your thoughts on spinal cord stimulators?
Yeah, so that's a very interesting question, because we know that unfortunately the medication that we have for pain and neuropathy are not always effective, and a lot of time people need a combination of multiple drugs, and despite that they still don't get a lot of relief. So people have been looking at spinal cord stimulator, and there have been clinical studies in diabetes and diabetic neuropathy, which is the most common type of neuropathy that we see in the US. And they found a very good response to spinal cord stimulator, really dramatic, actually, if you want to believe the data, amazing pain relief compared to typical oral medication. You have to be careful. The frequency of the spinal cord stimulator has to be set at 10 kilohertz, which is different from what is used for other problems. So people who are putting the spinal cord stimulator for painful neuropathy need to know how to regulate the device. The other good thing about spinal cord stimulator is that most of the time, if not always, the doctor will do they put an external stimulator and do a trial of 2 weeks to see if patients respond to treatment. And if they do, then they put the permanent stimulator, because it's an expensive device. And there's also complication when you put anything in the body, which, for example, you can have infection or migration of the electrodes, etc. But if they succeed the trial and they feel that it's beneficial, I think it's a good idea long-term, because then they may get better relief than medication and reduce the amount of medication they are on.
Okay, thank you. Okay, Dr. Maurer, if a patient with wild-type cardiac amyloidosis is receiving 2 Lasix infusions per week and orally takes 80 milligrams of Lasix twice a week, is this an indication of end-stage disease?
Not necessarily. So Lasix is what's called a loop diuretic. There are 3 main available loop diuretics in the United States. There's Lasix, or furosemide, that's the generic name. It's called Lasix, by the way, because it was last 6 hours. That's how it got its name. There's a drug called Bumex or bumetanide, which lasts longer. And there's a drug called torsemide or Demodex, which also lasts about 8 to 12 hours. Lasix is the standard loop diuretic that most people will administer, and it's pretty effective, but it has one major limitation, maybe several, but the main one is that it's poorly what we call bioavailable. That means when you put it in your mouth, how much gets absorbed. And in the setting of amyloid heart disease, where usually you have a lot of right heart failure, in which the blood backs up not into the lungs like it does in the left heart, but also into the liver and to the intestinal tract, I often say to patients, just like your legs can be swollen, so can the wall of your intestine. And then the ability of the medicine to be absorbed is markedly reduced. So Lasix, you could take 40 milligrams and absorb literally 4 milligrams, 10% of the drug. So you could take more and more and more, and you're not going to get it absorbed. So one thing that we often do for patients with amyloid at our center is we switch them from Lasix or furosemide to one of these other diuretics, Bumex, bumetanide, or torsemide or Demodex. Those are, 2 drugs with 2 different names, somewhat confusing, but they're much more bioavailable, meaning when you take them, 80% of them are absorbed. You don't need as high a dose. They're more effective and they last longer. So for example, if you're taking 80 milligrams of furosemide, you often only need 40 milligrams of torsemide or 2 milligrams of bumetanide. And that's one way to avoid what I think is happening to this patient. That is, they're receiving intravenous diuretics. Obviously, if you give them IV, you don't have to worry about absorption, but going to the hospital or to a doctor's office to get IV diuretics. The other drug I mentioned in my talk was these SGLT2 antagonists, right? The sodium glucose cotransporter inhibitors, the drugs that were originally developed to treat diabetes, Jardiance or Farxiga. And those are medicines that I think work very well in combination. The other diuretic we often use is a very weak diuretic called aldactone or spironolactone, and that tends to work in combination with the loop diuretics to maintain your potassium so it doesn't go too low and you're not at risk for arrhythmias, and seems to have a synergistic effect. So I hope this patient has opportunities to switch. Obviously, the more diuretics you're taking, it is a marker for worse disease. The other thing to note is you always should try to work on the supply side, which is you eat all you want and whatever you want, and you're eating fast food and all sorts of other things laid in your body with a lot of salt, then you're going to have to take a lot of diuretics. So alternative to just escalating the dose of diuretics is to see a nutritionist and get some counseling about how you might be able to limit some salt in your body without becoming malnourished.
Super. Okay. Now, here's one that, it sounds like the physician might be a little criminal here. I was diagnosed 5 years plus ago with wild type. I've had heart biopsies on both my left and right side of my heart at Mayo to confirm that I have ATTR wild type. However, all my PYP tests have come back negative, but am in the hospital with amyloid related issues a couple of times each year. They keep telling me I'm not eligible for a trial because of my negative PYP tests. Why?
I don't know. If someone has biopsy proven cardiac amyloid that's transthyretin in nature, they would be, as far as I know, because I take care of such patients, eligible for all clinical trials. As I mentioned, PYP is a great test. It's a replacement for a biopsy, but it's not the gold standard. An endomyocardial biopsy like this patient had is the gold standard. It's pretty unusual to need a biopsy of your right and left heart. We only usually do right heart. Amyloid diffusely affects the heart. So there's probably some, nuances to the story, but in general, if you've had a positive endomyocardial biopsy that shows TTR amyloid, you're eligible for all the clinical trials, assuming you meet all the other criteria.
Okay, great. Okay, this person is on Vyndamax. He's on wild type. He's on Vyndamax. He's on Eliquis. He says doing a great job of controlling the progression of his disease. However, he has peripheral neuropathy, and we hear a lot of our wild type patients talking about peripheral neuropathy. And he says he has peripheral neuropathy. His growing walking and balance deficits are quite troubling. He wants to know if the wild type and the lumbar stenosis is working in concert to worsen these problems. He needs an explanation of exactly what's going on. So.
Yeah, I'll start, and I'm sure. Oh, go ahead, Karam.
No, please do.
Yeah, I think that we've all learned, as we were saying before, that this oversimplification, many patients with wild type disease have similar symptoms. Lumbar spinal stenosis is quite common clinically. I would say it's 30 to 50% of the patients. It's quite debilitating. It sounds like a lot of the symptoms are either attributable to the lumbar spinal stenosis and or a concomitant peripheral neuropathy. So it's not unusual. And I think we've probably oversimplified and mischaracterized the disease in articles and other things. So as we learn more, I think we're appreciating. To be honest, it's a major concern for most of my patients. I wish I had training better in orthopedics, because I feel like orthopedic manifestations are what really limits people, sometimes more than the cardiac issues lately.
Dr. Karam?
Yeah, I think that the additional investigation are necessary in this situation to say, is it more the neuropathy or is it more the spinal stenosis that are causing these symptoms? The spinal stenosis, the treatment is, if it's severe, a surgical option can be explored if adequate. For the neuropathy, Dr. Maurer and I mentioned before that amyloid treatment is amyloid treatment. So right now in the US, we have specific drugs for neuropathy and other drugs for cardiomyopathy. But, as long as the patient is on one of them, it should be addressing also the neuropathy. And then finally, as I mentioned before, there are many reasons why people get neuropathy. So you can have vitamin deficiency or diabetes or other reason to get neuropathy. So these would also need to be investigated and ruled out.
Okay, now here's something that we see crop up a lot. Okay, nasal drip, congestion, phlegm, which you discussed earlier, kind of a chronic little cough, which we discussed earlier, and I know, Dr. Karam, you've made a recent discovery about sleep apnea. Are these all related from the same area, or what? Is this something new, or what?
I think Dr. Maurer gave a very nice explanation of the reason why people get congestion and phlegm, and I think that's very reasonable. The sleep apnea is, as you mentioned, is something that apparently is common in the survey that we did with people with amyloidosis, thanks to your help, Muriel. And amyloid deposits everywhere, and when it deposits, cause restriction of movement. So the question, could it be depositing in the throat, and you have the congestion as well, and that can cause more tightening or constriction of the airways, causing the sleep apnea? Is there more of a central involvement with the brain and the breathing centers that are in the brain. So there's many different explanations. I think this is, we don't really have a very good explanation, but I think what Dr. Maurer suggested, that maybe local amyloid deposit in the throat can contribute to these symptoms as well.
Okay, we're running towards the end of the road here, but we'll take a couple of more, and then I'll ask you doctors again to be so kind as to answer the questions via email. I was hoping we get, we always get more than we think, right? Okay, so everyone that's listening, you will get your questions answered, even if they were not answered live today. Okay, for tafamidis, do we know the ratio of the number of stabilized TTRs to the volume produced by the liver on average per day or per specific time period, i.e. what percentage of TTRs are stabilized? Who wants to take this?
I'll start. It's a great question. We don't know, to be frank. Interestingly, there are certain really unstable forms of TTR, not wild type, in which the variants cause such instability that they're probably not even secreted by the liver. They're degraded immediately. Those usually end up causing forms of TTR amyloid involve the leptomeninges and around the brain. But there are assays to measure how stable TTR is. Jeff Kelly, with data from our group years ago, invented one in which you can essentially expose transthyretin to a detergent, it's called urea, and see how quickly it breaks apart. And then the setting of stabilizer therapy show that it doesn't break apart as much or less. Those kind of assays, though, haven't been thought to be needed, because when you use high dosages of stabilizers, almost everyone is fully stabilized. But yeah, the biology of the disease requires further investigation.
Okay. Okay. Well, let's see. We'll start on another one. Okay. Bending over to pick things up causes me fatigue and very labored breathing. His lungs were checked and are okay. So is bending over that kind of a neuropathy thing? I see some nodding.
No, it's usually a cardiac thing.
Oh, really?
It's actually called bendopnea, BENDOPNEA. Apnea means shorter breath. Bend means when you bend over. Orthopnea is also when you.
Did you make that term up?
No. Mark Drasner described it about 10 years ago in heart failure patients. Orthopnea, so is when you lie down, you get shorter breath. They're both related. So that's why cardiologists ask you all the time, how many pillows are you sleeping on and whether you need to prop your head up. The worsening your heart failure is. So the explanation here is that the pressures inside your heart drive how short of breath you are. When you lie down, you redistribute the blood in your body and more comes back to the heart, because a lot of it's sitting in your belly, in your liver, your spleen, and your splanchnic bed, so to speak. That's the belly blood vessels, and in your legs. When you bend over, you increase the pressure inside your abdomen, and that compresses veins that usually store quite a bit of your blood. It turns out that 70% of all of our blood in our body is stored in the veins. And when you bend over, you push that blood back to your heart. And if your heart already is leathery and thick and has a high pressure inside of it, those pressures can shoot up. So many patients will say, wow, I get pretty wiped out, believe it or not, when I lean over to tie my shoes. It's really very difficult to do. And that's concordant with the fact that the disease is affected, I think, the filling pressures inside the heart.
Okay, I'm a normal average person, semi sort of. And when I bend over to get the dog's bowl, I get a little dizzy and stuff. Is that normal?
Yeah, probably. But the patient, I think, who's describing their symptoms is probably much more severe. So everyone, when they bend over, will increase the pressure in their belly and shunt more blood back to the heart. But if your heart is normal, and it's not leathery, it'll handle it. Some people get some mild symptoms, but many, many patients with amyloid complain a lot of that. I mean, it's not a rare phenomenon. Again, you can tell your doctor, if they're not aware of it, tell them to look up the term bendopnea, written by Dr. Drasner at the UT Southwestern. He coined the term about 10 years ago. Okay,
great. We'll take one last one. Okay. This is a person that has itchy scalp, and a biopsy indicated it was seborrheic keratosis. Is there any other relation? Is there a relationship between TTR amyloidosis and seborrhea keratosis that anyone knows of?
Not that I'm aware of. Seborrhea keratosis is a term usually meaning kind of dry skin. But not that I'm aware of, but there are lots of things that are associated that I'm not aware of. Sure, if Claudio is still with us, he would know the association in a second.
Okay.
Claudio.
Well, all right. I all good things must come to an end, right? So I do want to thank you all for coming today and giving us your Saturday. And Dr. Maurer, I know you had a death in your family, and we certainly appreciate your making time for us and not canceling out. That was above and beyond for sure. And we do want to say that this will be up on our website and YouTube channel in a couple of weeks. There will be a survey at the end of this when you leave, so we would appreciate it if everyone would take time to fill it out. We will also share the tape today with One Amyloidosis Voice in our Facebook groups. We want everyone to stay safe, stay healthy, get all your shots, okay? And remember, we're available all the time. You can email Muriel at amyloidosissupport.org. Give us a call. We prefer no calls after 10 p.m. Central, but it's okay. We understand sometimes there's emergencies, okay? So we will get back to everyone with all your questions. Thank you, thank you, thank you. I can't say enough to everyone. We appreciate you all so much.
Thank you, Muriel. You're amazing. So thank you very much.
Thank you all. Goodbye.